Well, thanks for the introduction, Rose. But yeah, I'm Bridget Ford and I work at the Headache Clinic, so Senior Headache Consultant and Shareholder and Director of the Christchurch Clinic. What I just want to do first of all is give you an overview of how the Headache Clinic actually came about. So Helen Tufuri is our founder up here. So we've actually just had our 10th birthday, so quite an achievement. So Helen actually started the Headache Clinic herself because she'd had a concussion injury and she had ongoing symptoms. And New Zealand at the time didn't have the means of treating the symptoms she had. So she looked at other ways to get relief and found the Watson headache approach, which Dean Watson, who teaches us, is based in Adelaide, Australia. So she went over to learn the technique, got huge relief from that herself, and then brought that back to New Zealand. Approached her employer at the time. She was in a musculoskeletal practice and said, I want to do 2 days a week of solely doing headache and migraine. And they said, well, you're not going to have, there's not enough demand, you won't have enough people. So Helen went and set up from her house at home originally and soon found she was definitely enough demand. She was overwhelmed by the demand and was working 5 days a week solely with headache and migraine and had a 2-month waiting list. So this is how we've now expanded. So we're nationwide now. Auckland followed Invercargill and then Christchurch, but now we have clinics all across. So we're at Invercargill, Dunedin, Wanaka, Christchurch, Nelson, Wellington, Hamilton and Auckland. So we're trying to spread ourselves so people aren't having to travel quite so much. So that's how we've come about. So in terms of what I want to talk about today, obviously you want to talk about headache and migraine, which is solely a big part of what we treat, but we're also treating a lot of concussion, both acutely and persistently. Okay, so this is coming up more and more. I then want to link all of that together along with what you guys experience in terms of the chronic fatigue and the long COVID. I'll then go through some case studies, a couple of case studies that link all of these together so you can see the results we get and how it all links. And then at the end I want to give you some simple postural tips to how to help with your posture, offload the neck and help potentially with some of your symptoms. If you've got questions, because it is a smaller group, by all means you can ask as we go, but I think by the end it's probably better to ask some questions at the end if you've got some. So the facts. So there's actually a common underlying condition in headache and migraine, and what that is a sensitized brainstem. Now your brainstem sits at the base of the head, or base of the brain, and connects the brain to the spinal cord. It literally sits within the top 3 levels of the neck. So it receives information from 2 different sources. One source is the top 3 levels of the neck. So it feeds in, it has the information from the neck about where the neck is sitting and how it's moving. It also then receives all the information from all the nerves in your head. Okay, now that's your ears, your eyes, everything feeds into that brainstem as well. Then those 2 messages together get sent up to the brain, and the brain decides what to do with those messages and processes that. So sometimes what will happen, you will have a dysfunction in your neck, which causes this sensitized brainstem, yet some people will have neck pain. So 80% of migraineurs actually experience neck pain and stiffness. Others don't feel any pain or stiffness in their neck, it's all the symptoms in their head, and others will have both, okay? 52% of the global population are affected by a headache disorder every year, so it's a huge amount, hence why we are now nationwide and the demand that we have. Going back to that sensitized brainstem, how that all correlates is if the neck isn't sitting where it should be sitting, it feeds in noxious input into that brainstem. So that's information that's not happy, it's saying I'm not in a good position. So picture, if you like, a parent being nagged by whatever age child, where they get nagged. Now eventually you're going to get to the point where the parent's going to snap, and we're going to have this sort of scenario, which potentially if you've got children, you'll know what this looks like. This is what happens to the brainstem when it's had this input from the neck for enough times. It goes, I've had enough. So it becomes sensitized. What that in essence means is there then is a decreased tolerance for normal everyday events. Most common ones is stress, dehydration and tiredness, okay? Then what can come in is hormones and what we eat or drink. So some people that we see have really obvious triggers. They go, right, if I eat cheese or if I eat chocolate, I'm going to get a migraine. If I have a late night, I'm going to get a migraine. If I have stress at work, I'm going to get a migraine. So some people have specific things that they know. Some people know on day 2 of my period, I'm going to get a migraine or a headache. Others, it's an accumulation of all of those things. So easiest way to picture it, and this will be similar in some of your conditions as well, is the brainstem has a volume, it has a tolerance, okay? Now, if the neck is dysfunctional, what happens is some of that volume is actually taken up by that dysfunction. So there's less room for all these day-to-day activities or day-to-day things, such as stress, tiredness, and the overflow is your headache or migraine presentation. So what we look at is giving you back your normal volume by correcting the neck and offloading that dysfunction so that you can then cope with more. So what I want to go through is the common presentations of what we see. So people have in their mind what a typical headache and migraine is, but there's actually over 300 different classifications of headache and migraine. It's numerous. So this is just a small picture, but I just want to run through some of these with you. So common one we see is abdominal migraine, more in children, because when the pain system is not fully developed, your vagus nerve, which is the nerve that supplies your gastrointestinal tract, comes from your neck. So hence why some children will actually get tummy pain or they will get cyclic vomiting. So it will follow a pattern and a frequency similar to a migraine or a headache, but they actually vomit. Some will get head pain with that, some don't get any head pain. And then later in people's histories, when we have some people come in with a 30, 40 plus year history, they've often had colic as a baby, then they go on to get tummy pain, then they go on to get headache or migraine, and that progresses. So it can be quite a picture. As I talked about before with the menstrual migraine here, you can have 2 types of a pure menstrual migraine and then a menstrual related migraine. So a pure menstrual migraine is, as I said to you, some people know on exactly what day of their cycle they are going to get a headache or a migraine, and then they know how many days that's going to last for. A menstrual related migrainers know that they're going to get it sometime around their cycle, but they don't know the exact day. So with that, that's often those people have a very normal hormone profile. So it's actually not an issue with hormones, it's the issue with the sensitized brainstem picking up on when those hormones fluctuate or when those hormones change. Now I'm talking about that in the menstrual migraine. When I talk about hormones going through puberty, obviously younger males, they can get an influx in there or a start of headache and migraine around that time when hormones change there as well. They're obviously not going to get the cyclical one though. Vestibular migraine is more, some people don't actually get head pain. They'll actually get dizziness, feeling off balance. It can be with nausea, it can be with vomiting, and can be sort of more visual changes. So quite a different one. So a lot of people there aren't even aware that that's a migraine. So that's a common one we see and can treat very effectively. Cluster headaches are quite different from clusters of headaches. So a cluster headache is basically renamed a suicide headache. Very, very painful. Again, can be treated really well. And with the cluster headache, what you'll find is that is very, very, so some people will know literally to the day of what time in the year they're going to get their cluster headaches. So very, very regular in their pattern. Migraine with aura. So a lot of people, and this is probably what a lot of people deem as your typical migraine, is that they'll get a change in their vision. So that's the aura. So that can be vision changes, that can be balance, that can be the nausea, but it basically can last minutes to, often sort of half an hour. I haven't had many that would be more than that, and then it's followed by the head pain. Though some people can get that aura and then no head pain as well. So differences there. We'll then see constant headache, which is more what people deem as that constant is often the band or pressure through the forehead, but this is 24/7. Doesn't go away. Can vary in intensity for some people, others it is just there at the same level all the time. So obviously a hard one to have to live with. Tension type headache can be similar to the constant headache in terms of the sensation people feel, but it's more like a band, or like you've got a tight hat or pressure through the forehead is typically that tension type headache. We also see a lot of people with sinus pain, and they've often been to the ENT, they've checked all of that out, they've had that scanned, but actually this pain can actually still be a headache, a form of a headache, because remember, all the nerves of the head are feeding into that brainstem, so that pain can be anywhere in the head. So I've also had people that come in with ear pain or eye pain, and it's still, headache or migraine, just the pain is in a different area. So commonly what we see in people's history is there can be that history of trauma. So often there's a whiplash injury, car accident, concussion, horse riding or motorbikes when they're younger or through, car racing, I've had one, so jet boating, so looking at that. Some people don't have any history of trauma though, so it's not a necessary precursor. Commonly we see people developing headache or migraine when they've had an increased period of stress in their life. So this can be emotional, this can be work, so that comes down to where people have gone from high school to uni, they've gone from uni to starting a job, or they're having a new or altered job. So that can be the stress component, but also what comes into that is the change in positions and posture is what we'll see commonly with that as well. So I'll go into that in more detail. So that's where that load on the neck is coming in, and if there can be an underlying dysfunction that's happened from this history of trauma, but at the time not necessarily getting headaches or migraines, and then that's loaded up, that brainstem's loaded up when we get the stress coming in or altered posture again. Commonly, as I said, mentioned before, onset of puberty, where there's the hormone change rapidly comes in, but also where people become body conscious. So being that body conscious, we'll see that posture rapidly changes as well and loads up the neck. So quite a common time that we see that coming in. Another sort of common presentation is people returning to or starting exercise. Because if people get into certain positions, so arms out in front and arms above shoulder height will load up the neck quite a lot more. So if there again is an underlying dysfunction there or weakness, that will load that up more. So that, as I said, just as a brief outline of that. The impact that this then has on here, and this, I'm sure some of this will ring true for a lot of you guys and what you're experiencing, but what we'll see is a lot of people come in with this, they have poor concentration, fatigue, muscle and joint aches that can be during, before and after. They'll have the sensitivity to light or noise, which for some people can be a trigger, so it can trigger them, or when they are in their migraine, they'll find they need a dark, quiet room. That can, of course, we can have lack of motivation with this. A lot of people will have poor memory and things that they are. Literally was talking to a patient this morning who's coming in, and she couldn't remember her husband's email address. Just something that she would, she knows, but couldn't remember it at the time. Poor tolerance, and this can be to any sort of scenario, coming back to that sensitivity to light or noise, but a lot of people don't like to go to noisy social gatherings, they can't handle a party at home. So a lot of people are then missing out on social things, so that has a real impact. The insomnia or lack of sleep comes in with this. Part of this can be that discomfort in the neck and not being able to get comfortable, but also the pain levels. Brain fog, another common one. With all this, obviously going to get some changes to mood and behaviour. That's then linked to poor productivity at home or at work. So people, they push through, but they're not operating at 100%. That then leads to frustration with all of this. And then a lot of it can be relationship strain, so whether that's with children, partner, husband or wife, because of what's going on. Because for a lot of people, and again, like what you guys will have, not everyone can see what you're feeling. So it's hard for some people outside of that to know how bad and the effect that's having. So that comes in there as well. Prevention, so what we do, obviously we look at the neck and we will correct any dysfunction we see, but we also look at posture and how we hold ourselves. Because our head is really heavy. It weighs between 5.5 to 7 kgs. It's quite a weight. And so what we have I have a 6 kg kettlebell in my clinic, and so what we do is we get people to hang on to it out here, to feel the difference of it out here, to when it's in here, okay? Because a lot of us have our heads out here. Now, every extra centimetre we take our head forward, that adds another kilogram of weight to what your neck and your shoulders are having to hang on to. So if you've got your head way out here, you're potentially hanging on to 10, 12 kgs through your neck, all right? So it, over time, we'll load that up. For some people, as soon as they go into that posture, they know straight away it's not happy. Others, it can be quite a time thing. So that all depends on different people's relevance, sensitivity or tolerance, I should say. Another good thing is taking breaks. So this can be that change in posture, change in position, brain breaks. Great to have a lunchtime walk, getting out into the fresh air. Again, you're more upright, you're changing your position. We do look, and I'll come into this more later as well, is looking at a low inflammatory lifestyle, which I know will link with a lot of what you guys are experiencing as well. But what we commonly see is there is a threshold, there is a high inflammation in the body, and that will mean that they are less tolerant to what's going on in their neck as well, and other things. And then we also look at neck strength and mobility. So we give a lot of people different exercises and some home exercises. So we're all about self-management so that people can manage this and have some tools to take control, because it's quite a condition where people feel out of control of their own lives with this. So just to show you the effect of the posture, so there's a really nice picture to show you. So obviously this one on the left, you can see this line. So her ears, we talk about the ear being level with the acromion in the shoulder, you can see it's quite a way forward here. So we are talking, she's probably got that about that 4 or 5 centimetres. There is a huge amount of weight going through this top part of the neck, and then it does and come down to the shoulders here. You'll see when she corrects it here on the right, beautifully in line, and that's a huge way to offload the neck and shoulders. Some people, we found this with COVID where we were in lockdown, some people with posture alone have been able to, really offload their symptoms. So we found this really nicely through the lockdown. Others, they need the treatment to be able to achieve that good posture. And others need both together, but it is amazing, posture alone, the effect that can have for people. So that was one bonus of lockdown for us. So next I'm going to go into concussion, because it's quite prevalent in the media now, just to go through what that is, how that presents, and again how that can link with everything. So concussion is a mild traumatic brain injury. So what that means is it's something that it's not permanent, we can fully recover from that if it's managed properly. It typically is from a direct blow to the head, face or neck, or it can be elsewhere in the body with an impulsive force, okay? So you don't actually have to hit the head to get a concussion. You can fall heavily and get a whiplash, jarring type motion, or you can actually get it, so say, car accident, and you don't hit your head, but you've got the seatbelt that stops you, and you have that whiplash injury. So it's an acceleration injury. So basically what it is, it used to be thought of that it was a bruise, so like a nut in a jar, and that brain would move and it would bruise. It's actually a stretching, shearing injury, okay? So the easiest way to think of this is, think of a big blob of jelly on a plate, okay? We move that plate, the jelly is going to stretch and morph and come back, okay? So that's what happens in the brain. The brain's got 2 densities of matter in the grey and white matter. So because they're different densities, they move at different paces, and that creates that shearing force. When you get the shearing force, what happens in the brain, there are millions of neurons, so cells are connected by axons and they connect to lots of other neurons. So imagine almost like an octopus, okay? So when you get that shearing, stretching, the axon that connects those neurons, it opens. And what that allows is the molecules outside that axon come in and the molecules inside that axon go out. That stimulates an action potential, which tells that next neuron, right, well, we're activating, we're exciting. What that does, it sets off a massive, and this is this excitatory phase, it sets off a massive, basically it would be like an epileptic fit if you saw it in terms of excitability in the brain, just for an instant, okay? That is then followed by a spreading depression. Now you can, in this excitatory phase, sometimes you can see this externally, so Some concussions, if you've seen them on TV, you'll see the person get it and then they either get up, they look like they're drunk, or they can actually have looks like a little bit of a fit, and then they're fine. That's that excitatory phase, but you're not going to see that on everybody. So this spreading depression episode is an energy deficit, is what we get in the brain, okay? So I'm going to show you this in a graph form. This is what happens in it. We're going to talk about returning to sport too soon, but this is returning to any activities too soon, basically. But basically, if we took at this top line, so before your concussion, your brain energy levels at 100%, okay? What happens at this point here, you're getting the concussion. So what naturally happens is this brain energy level, this is ATP. So as soon as this excitatory phase happens, we get a drop in energy because ATP is used to try and balance out that metabolic process that's happened, okay? And over time, if that is managed properly, that naturally will come back up to normal, okay? Now this can take anywhere from sort of that 22 to 32 days for that brain to fully recover. Some people, it can be longer, often children this is longer, or if someone's had predisposed or conditions before this, then this can be longer, but ultimately it will recover. What I just wanted to show you here is where a lot of people get caught out is some people, often at day 17, will have no symptoms here, okay? But you know from what I've just shown you here, the brain is not fully recovered here. It's not back up to its normal metabolic level. It's very vulnerable. This is when some people are going, well, I'm symptom free, I'll go back to sport, I'll go back to activity, at risk of getting another knock or another concussion. Then what happens, that happens again when we get this excitability, we get another drop in energy, and then what happens here is this is accumulative. So this can get to the point where we are getting to cell death, okay? This is when it's permanent, okay? But a concussion here that fully recovers, and then another concussion here with enough space where it's fully recovered, they're separate, okay? It's only when they're accumulative that we're looking at potential cell death or potential permanent. There have been a couple of cases in New Zealand where it actually has resulted in death, okay, where someone has gone back too soon. There are a couple of league players, and they haven't come out the other side, okay. So big one with this is basically if you are symptom free, it doesn't mean your brain is fully recovered. So what we look at, we have numerous tests we can do that tell us if people are back to normal, but you need to have a baseline, ideally have a baseline before. So typically that's why it's coming out to sports players, but we have concussions happening at any time for people. So facts around concussion is people are 6 times more likely to have another concussion if they've already had one. Why this often is people, they've either, so what happens with you'll see down the bottom here, I'll get to this bit, with a concussion, the average force is 96 G of force, and all that's needed to disrupt or cause injury to the cervical spine is 4.5 G of force. So what happens, and that's why we're seeing these people as well, is with the concussion they're getting a whiplash injury. They go together. So some people, they won't get many symptoms, the symptoms resolve, so they're like, I'm fully recovered, but their neck can actually then still be dysfunctional. What that then means is it's weaker and they can get a concussion with less force, okay? So hence that's one of the reasons. The other thing can be is people can have poor balance, poor concentration, not great decision making after concussion. Again, not see that as a symptom of concussion, go back to things too soon, and again can make that more likely. The highest volume of concussions occurs in 10 to 19-year-olds, probably more because they're more active and more likely to be playing sport. These guys don't often make the best decisions at the best of times, so it makes them a pretty vulnerable population. In terms of when we get symptoms of a concussion, so the concussion symptoms are actually pretty much the same as whiplash symptoms. So at the time you are unsure to know whether that is the concussion itself or the neck, so hence why we look at both. Now children and adolescents, why they're often more predisposed to cervical injury and concussion is children are almost like bobbleheads, okay? So our head develops a lot faster than what our body does. So a 4-year-old, their body weight is at 18% of what it would be as an adult, and then their head though is 90% of its full size. And then when we get to a 12-year-old, the head is 95% of its full size, and the body weight is still under 50%, so high 40s that the body weight is. So hence why they are more predisposed and can take longer to recover. Going through concussion symptoms, you are again going to see some link to what I've talked about with headache and migraine, and no doubt what you guys are experiencing. So headache is a common one. Again, fatigue, very, very common. Dizziness, again that sensitivity to light or noise. Often the poor concentration and the poor memory. So these can be, you can get, just some of these, some people get all of these. Dazed or confused. They often have a slower reaction time, which isn't always going to be picked up without testing that. Often there's a visual impairment. Again, that poor tolerance to high stimulus situations. So very commonly after concussion, people hard to get back to school, back to work. It's the noise, it's the lights, it's the busyness. There's the nausea coming with that. Again, the insomnia. Again, the brain fog. The tinnitus, so the ringing in the ears. Often people will get that straight after a concussion. That can linger. Again, this changes to mood and behaviour, and then the poor balance. So like I said, you're seeing the link between the two of these so far. So then I wanted to link it with what you guys are possibly experiencing. In terms of research, it can be limited in terms of that scientific research. So a lot of this is going to be what I experience in clinic, but some of it is the research. So epidemiological studies have linked migraine with other systemic conditions. So got the depression, anxiety, so we see this very, very commonly. Irritable bowel syndrome, the fibromyalgia, sleep disorders, chronic fatigue, and as well as cognitive disorders. In all these things, fatigue is the most common linking symptom that we do see in the clinic. Fatigue's also one of the most common symptoms both before and after a migraine. So a lot of people know their migraine is coming because they will start to yawn, they'll start to feel more tired even before they get any symptoms or pain. And then a lot of people after their migraine, all their symptoms resolve, but they have what they call a hangover period, where they just feel wiped out, tired for about a day or two. It does vary for different people. And then it's estimated that 60% of migraine is actually pathologic fatigue. So like what some of you guys are no doubt getting, where it's actually all the time, and it affects everything with this. Probably, so it's going to affect their motivation. It then can affect the sleep. It can then affect, because they're not exercising the same, and so then if you're not sleeping well, we get basically into a vicious cycle with this happening, because then you've got the low mood from that as well. So basically what we look at, so yes, we treat the neck, and yes, we treat that dysfunction, but we also take a very holistic approach because it's got to be a wraparound. So our main, yes, we're based on the Watson headache technique, but through our 10 years of being in this line of work, we've realised we've got to address other situations. So we work closely with people's sleep hygiene. So that's looking at sleep patterns, whether it's waking and going to bed at the same time, reducing bright light before bed and high stimulus, trying to wake with natural light. Some people respond really well to blue light in the morning. We then we use the sleep drops supplements, so magnesium and their sleep products, which helps with getting a full night's sleep and also helping to calm down to get to sleep. We then obviously the spical dysfunction correction we look at, and we also look at diet. So again, I'm seeing from some of your books over here, so a low inflammatory diet has been really, really beneficial. So we've just connected with a nutritionist, dietitian in Australia who does a low inflammatory 3-week reset diet for us that people can then continue with, but it's had some amazing results. Because basically what we're trying to do, we're aiming to reduce the load or the overwhelm on that system. And as I said, predominantly what we see, there is a huge cervical relevancy. And if that's the most relevant part, then we get some massive results with that. Others, it's relevant, but there's other systems or other parts that are just as relevant or closely relevant that have to be addressed as well. So we do look at balance of the central nervous system. So the central nervous system is located in that brainstem as well. So this is we have your parasympathetic nervous system, which is your rest and digest phase. And then you have your sympathetic nervous system, which is your flight or fight phase. So we often see people that are stuck in this sympathetic phase. So what we need to do is, they can't both be high, so we need to balance them out. So we're commonly having to come in and activate this parasympathetic nervous system, which is through vagal nerve stimulation, which I'd mentioned was what supplies the gastrointestinal tract. Lots of different ways you can stimulate this, but just to name a few, there's the diaphragmatic breathing, there's grounding, there's cold water therapy, humming and gargling are some of them. And then, as I talked about that chronic inflammation, we're seeing this more and more. So I've got predominantly one lady at the moment who's done so well on this diet. So she's coming to see me for headache and migraine, but she, on a side note, has had bilateral hip pain that she would normally need a cortisone injection every 1 to 2 years. She was trying to spread that out as long as she could because she was having to pay for that privately, and she could barely get onto the plinth and roll and turn around. So I got her onto the reset low inflammatory diet, and she now can now come in. She hops on the bed, moves around, she's walking quite comfortably, and this is literally just from changing her diet. We haven't done anything to her hips. I haven't treated her hips. So diet alone has been massive for her, and it's been decreasing her headache and migraine as well as with the treatment we're doing. Now, in terms of long COVID, it's because it is a relatively new condition. It's hard to get specific research and evidence on that, but through what I have seen in the clinic and through my experience, the symptoms that we see, people coming in with long COVID, are very, very similar to what people get with headache and migraine, of showing a sensitized brainstem. So that brings me to my first case study. So this study was a 72-year-old woman, She had a 15-year history of migraine, so that's what she initially came to see us about. She would get bilateral head pain, so pain on both sides, and eye pain, and it would get up to a 5 out of 10 level. She would be photosensitive, so sensitive to light. She would always get nausea, and she would occasionally vomit with it. The duration was 1 to 2 days that this would last for. So if she was having a bad run, she could get this 3 times a week, which if you equate that up, she might have only had 1-2 days relief in a week, and at best she could go for 6 weeks. She'd had CT and MRI scans of the brain and sinus investigations, nothing detected on those. In general health, she had allergies, some digestive problems, and osteoporosis. So she came in for treatment, and did really well with us correcting her cervical dysfunction. So then she actually had a really big break before she came back again. When she came back, her migraines had been much less frequent, so she probably was getting about 1 every 3-4 months. But she'd noticed she'd been waking with headaches for the last 3 months before coming in. So when we dug into what had happened since she'd been in, she had COVID in October of 2022, and then this lingered, and she was diagnosed with long COVID. So her symptoms that she was getting was brain fog, fatigue, POTS, so that's that sudden change in blood pressure with postural changes. She was getting malaise after any exertion. She was sensitive to light and sound. She was getting short-term memory loss and balance issues. So these were all new symptoms for her. So she came back for treatment, see me in May 2023. So I was listening to this and I said, well, that sounds very much like a sensitized brainstem. So she came back because of the headaches, but then when I heard this in her history, I was like, well, let's see what we can do about this as well. So I corrected the dysfunction in the top part of her neck, and when she came back for that next session after that, she had a clearer head, she felt more alert and awake, and she wasn't feeling like she was on a ship anymore. So that was her balance. She just felt like she was constantly on a ship. We put her had 1 or 2 in this time, but when we got to a 3.5 week gap, so we spread her right out, her brain fog had completely cleared, and she was walking every day, and her vision was clear. So we were able to change a huge amount of her symptoms with that. To know whether what we see commonly in the clinic is a lot of people will have a history of headache or migraine. Obviously COVID is, it's in our community, so we'll find a lot of people's symptoms will get worse when they've had COVID or when they've had a flu or a cold. Whether this is because of, the system being overwhelmed by something else coming into it, or we then go, if you're feeling like that, you've got no energy, you're not feeling well, you're either in bed, you're sitting a lot, you're not active. So again, there's that postural load and that load on the neck. So unclear as to which, again, is playing in more, but in this case, correcting her cervical dysfunction gave her huge, huge relief. And the next case study I've got links a few different things together. So this is a 21-year-old female, came to see me more for her migraines to start. So she worked part-time at the supermarket when she came in, but she was normally full-time at uni, so she's just in her holidays. She'd had a 9-year history of migraines, so alternating pain, so it would switch sides, and it would either be in her eye and back of the head. So she would get an aura just before her head pain, so that's where she would lose vision. She was always nauseous, so some people will sometimes be nauseous, so always nauseous with her migraine, and she would normally vomit, but that actually gave her relief. So some people get relief to vomit. The intensity of hers would ramp up really quickly. So she was either low or she was 10 out of 10. So it would really, really increase quickly. And they would last anywhere from 6 hours to 3 days. So she came to me because they were getting more frequent. So she was getting one of these a week. And best she could go for 5 weeks without. General health, she would get sick multiple times in the year, and she'd normally find that she'd be quite bad, quite sick for about a week with those illnesses. What she also had going on in the background is her mum had been diagnosed with cancer and wasn't well, so she had some emotional stress going on in the background too. So she responded really, really well, again, to neck treatment. So we got her to a new frequency of best of 12 weeks. We pretty much doubled that out. And then any migraines she was getting were half of what they were and not lasting for anywhere near as long. So she was tracking quite well with her, and then she got a concussion injury with soccer. So she slipped, fell and whacked the back of her head. So this brought on a constant dizziness, which would vary from that one at best, 4 on average, 7 at worst. And she was getting headaches and nausea, okay? So we treated the neck, the dysfunction, addressed the concussion aspect, and she settled quite nicely with that. What this brought up though, so she'd had sort of an underlying sort of where she'd have to pace herself, but after the concussion, she was then actually diagnosed with chronic fatigue. So this really became prevalent for her, and she was seeing a naturopath. So taking what she described as some horrible tasting herbs, but they really, really did help her. So she actually did really, really well with this. So whether the fatigue was brought on by the concussion or a true chronic fatigue, but she definitely had that. So headaches and the dizziness all settled. So when I last saw her, we'd had a 6-month gap between treatments. So she had no headaches or migraines, so they'd pretty much all gone. Her fatigue had greatly improved, so she was going to the gym 1 to 2 times a week, football times 2 a week, and she actually was doing her Masters in Environmental Science at uni. So she, back here, because she'd gone back to part-time uni, and she was only really playing soccer. She couldn't do the practices, she could play like half a game, she found she could do a little bit, so massive, massive change for her. So really nice turnaround for her, but just showing the link of all of those together. So what I then want to leave you with in terms of some simple tips for posture that I can give you guys, and then we can go through some questions. But simple tips of what we give people is, a lot of people we do know about posture, but it's not just about pulling the shoulders back, it's actually about making an arch of your lower back and bringing the chest up when you're sitting, okay? So it starts from lower down. Another really nice tip is lying on the couch instead of sitting. So these chairs in here are quite good, but a lot of the chairs are really low and slumpy, and it's very, very hard to sit upright in them. So if you lie down on the couch and you have a pillow that fills this gap, your neck's completely offloaded and you can lie there for a long period of time and you're not putting any load on your neck there. Another really nice tip is making sure that your car seat is upright. So when you guys get back into your car, you can sit up with really nice tall posture, adjust your backrest to help support that posture, and then what you do is you adjust the rear view mirror, and then you don't touch your rear view mirror again. Okay, if you get in there and you can't see out your rear view mirror, you know your posture has come back down. Okay, so it's a really nice tip. The other thing I'd say is if you do wear your hair up, make sure it's either low or high, because that ponytail can push you forward in the seat. Another nice tip is nodding to look down instead of hanging your whole head over. So remembering how heavy your head is, you don't want to have your head hung over like this, because that's again loading up the neck. It's more trying to nod. Okay, so bringing things up to you is really helpful. So having phone, book, a laptop should not be on your lap. It should be on a pillow or on a desk so that it's at the right height for you. Another really nice one is not lying on your back with a pillow. So this is quite commonly people may read in bed with a couple of pillows behind their head. You're actually loading up your neck that way. So really nice exercise we give people, and it's so simple, and this then helps to stimulate the parasympathetic nervous system. It does grounding, it does diaphragmatic breathing. It's just to literally lie flat on your back with no pillow on the floor, 5-10 minutes a day, or what you can end up tolerating, because then you're helping with your posture, you're offloading your neck, but you're also calming down your breathing and helping to stimulate that parasympathetic nervous system. And the other motto we have is pulling your head in. So big one, to pull your head in when you're on the computer. So you'll see a lot of people have their heads out like this. So we often say to people, actually imagine that the screen smells bad, pull your head in, okay, in a nice way. So we have a nice wee turtle magnet that we give people just to help prompt with that. But just to show this visually for you, just to wrap up, I love this picture, but just showing us postural evolution. And you may have seen this before, but this is where, well, depending what you believe, this is where we started. We've got more upright, but now with technology, this is where we're heading, and this is unfortunately what you see a lot of people doing, and not the eye contact, not the saying hello, and then coming to this. So we are trying to keep us in the green, basically. So hopefully that's given you guys some nice tips and good information. So happy to open it up to questions if you want to ask me now, or we can answer them at the end. So either way there. But that's me in terms of slides, but happy if there's anything that has come up from that.
Neck exercises for strengthening the cervical part.
Yes. It's hard to give those to you without showing you specifically, because what happens in the neck, we have commonly the ones that get dysfunctional, not working so well, are the deep ones, okay? And they, if they're not working properly, our body's really good at compensating, and what it tends to do, it then brings in these big front ones to help support. And then these get dominant, but they're moving muscles. They're not made to stabilise and work all the time. So it's quite hard. You've actually got to repattern them first. But a big one you can do is literally just by sitting upright and keeping your head pulled in, that is going to start to strengthen your neck. Yeah. So basically having good posture. The other thing that can really help us if you're a gardener or all housework, unfortunately, we do a lot of leaning forward, is to actually hinge through your hips. And what that's going to do, because you're keeping everything in line, that's going to strengthen as well. So without, it's really hard to give specific ones, because you can get it quite wrong. If big things, if your neck's weak, I would recommend not doing any sit-ups. They're not good to do, because that will load your neck up. And if you're doing weights or anything, arms away from the body or arms above shoulder height will load up the neck if it's weak. So the ones we do, they're very gentle, basically a very gentle nod, but you can do it wrong if you're bringing in these big front ones.
Do you recommend, if you're doing weights, what do you recommend?
It's got to be progressive, so not doing sit-ups, and if you've got headache or neck pain, not doing weights out in front, and not doing weights above shoulder height. No.
Just do them?
Yes,
okay.
Yeah, until your neck was stronger. Yeah,
right.
Yeah, and that's got to be specific targeted stuff, and it's not one I can globally say to you, but say you would do it, it's just basically if you hold your posture really well and keep your head pulled in, that's going to give a basic strengthening with everything you do.
And for gardening, keep your neck in.
Yes, absolutely.
Right.
Yeah, absolutely. Yeah, but good question. Yeah. Any other questions, guys?
I was going to ask, can people self-refer to you? Or
Yes, absolutely. Yeah. So we actually, most people do self-refer. Most of our people come through word of mouth and Googling. GPs are very, very busy at the moment. I've done a lot of talks, I haven't done a lot, but recently trying to get around the GP practices that I can, and the ones that I have, then they are referring. So it's getting the knowledge out there that we hear. It's still, we are very busy, but it still amazes me how many people don't know about us, and I hate to hear that when people come in and we make such a difference to their lives, and then they go, why didn't someone tell me sooner, or why did we not know about you? So that's, that's what I'm trying to do through these talks, is raising that awareness. But yes, we definitely get some referrals, but majority is people self-referring, just coming in because they're fed up with not getting the help that they need through all the other systems that they've tried, basically. Yeah.
This question about cost, how much does it cost?
So it depends on age, and it depends if it's ACC. So generally so if you're over 65 or student, that's the cheaper rate. But for a standard rate for a private treatment, it is $2.55 for the hour, which is an initial assessment, and then the follow-ups are half an hour, and they're typically $1.55. So it varies. So ACC can make it sort of $50 cheaper on that initial, and $30 on the follow-up, and that's similar for the senior and student rate, I think. Yeah. So it is a private rate, unfortunately. What we do offer for people is we want to make it as accessible as we can, is we do offer some payment plans, so a payment plan option where people can pay a bit each week as opposed to doing it in a lump payment. So we have got different options there.
Low.
Medical insurance?
Yes, depending on your policy, absolutely. Yeah.
Low inflammatory diet.
Yeah.
Can you give us some clues or food?
Yes, well it's typically no gluten, low or no dairy, and basically it's high in your fruit and veggies, but low carb. Yeah. So I did the 3-week reset. It's quite interesting. I've always known I was gluten intolerant. Didn't know I was dairy intolerant until I took it out and tried to bring it back in. So it's amazing what we can have as an underlying, I sort of knew I had a sensitive tummy, but I didn't know dairy was an issue for me. So I'm trying to think. So basically for breakfast often, so minimal fruit. So there's berries and apples in there, but there's not too much other fruit. And it's cutting out the refined sugars as well. Yeah. So some people go, I can't do any of that, but the difference it makes, it is amazing. So high veggies, taking out your breads and your flours. Nuts are in there. Just trying to think what else, and so lots of eggs and lean protein basically. So there are all the fishes, fish and meats and different things in there.
Yeah, the vagus nerve stimulation is something that a lot of people in our community find help.
I thought it would be.
Yeah. So you mentioned an interesting list of or easy application ideas. Some people also use electrical devices. Have you had any experience with that, like the air positioning and stuff?
No, we don't. We haven't. We more use things that people can use without modalities in terms of the vagus nerve, but I know there are other ones, but no, we don't use those. Yeah, and I don't know too much about the specifics of those.
Right.
Yeah.
So you talked about humming and very simple things like that.
Very simple.
Is there evidence around those tools, or is it just people trying them out and seeing a difference?
There is evidence around that. There is. So it does, because the vagus nerve runs down, so the humming, it stimulates that through the muscles at this point. Yeah.
Right.
Yeah.
What was the benefit of that?
So it increases the parasympathetic nervous system, which is your rest and repair part of your central nervous system. So a lot of people are out of balance with that, and they go into fight or flight, so they can constantly feel stressed, under pressure, or just not jittery, but they're just on high alert basically. So the vagus nerve basically brings in that calming. Yeah, and that's what can usually feed into people not being able to sleep. So this comes back to evolution. So if your body feels like it's in pain or it can't escape from that bear or that tiger, it's not going to let you sleep fully, okay? So if you're in that fight or flight, it's saying there's danger, even though there isn't actual danger, it doesn't let you go into a deep sleep, or it won't let you sleep because of that. And so stimulating that parasympathetic nervous system and vagus stimulation can help with the sleep aspect as well, because it's calming your whole system down to say, well, actually, you're okay, there's no danger, you can sleep. Yeah, so it's like I said, it's quite a lot of people we see, and like we said, you get stuck on this wheel or this cycle, and you just need something to break out of it, to allow the body to do. Often the body's amazing, it can do its own thing, but it's got to have the right base to do it on, or right foundation, basically. Yeah.
I personally found, how you just worded that any elimination of something that's combating your body, and it only has to be reduced slightly to overall make quite a difference. And sometimes I don't think we tap into that enough, because I'm getting really good at noticing that and working with that more, because you suffer a bit less, and then everything else can start to be a bit less hideous as well.
Yeah.
They all hold hands.
They do, they really do.
It's quite interesting.
Yeah, so it's trying to find, like I said, if you find the system part that's putting in the majority, or there's the most relevant, the difference it can make is massive. And like I said, if people come in and their neck is a huge component of that, the difference and the immediate difference that can make is quite remarkable. It's still, you know, I love it. I'm quite addicted to this job. It's so amazing, the changes in people's quality of life that you can get from quite a simple, or very simple, non-invasive technique. Yeah, which is the cool thing. We don't use medication. Some people need medication to get to the point where things can be more effective, but we don't. It's not something we look at as a practice. Yeah.
Have you had any people successfully get funding from Work and Income for your fees?
Some.
Oh,
yeah,
right.
some.
Okay.
So yes, in terms of that, so some people, if they're on the disability allowance, yes, there can be funding for that. Yeah. What have I got? I've got 2 with that. Sometimes though, because we are having sort of your health navigators coming in and seeing what we can. So some people get an initial assessment, and then we're writing a letter. There's one we're waiting on. We don't get, we don't do it regularly, but we have had some. It's sort of yeah.
How often do you, if you're a new patient, how often would you come in before you start seeing?
Before we start seeing results.
Yeah.
So we normally say to people, we want to see a result within 3 treatments. We want to see some sort of change, and whether that's in people's frequency or duration or intensity or different symptoms. Some people will literally notice a difference straight away. So some people come in with a headache, 8 out of 10, we treat their neck, they sit up and it's either gone or it's very low, like a massive difference straight away. So some people do notice it straight up, others it can take a little bit of time, and that's just, it's like you all know, we're all individual, we all vary in how we respond to different things, and the speed and what our body might adapt or change. Yeah.
So what would be the frequency someone would probably see you like?
So if we went the sort of, some people around work, they can only come once a week. We're still going to get changes with that, but typically it's a little bit slower, because the cervical dysfunction that we see, when we first correct it, because the body's been used to going, so typically the neck will sit one or other side. It typically goes, oh, well, I've been used to being there. It tends to want to go back to that position. So that whole aim of this is keeping treatment momentum at the start. So typically we would see someone, say we saw someone on a Monday, we want to see them again that week, and again early the following week. Then we leave it a week, and in that time we've given people stretches and exercises to help keep the neck there. We check in a week, has the neck held that position, or is it still wanting to swing back? If it's holding, then we keep spreading it out, so then go to a fortnight, then a month. So pretty much, if it's all tracking well, we'd double. Some people will get to that week and it's moved a bit, we'll do a week again. So it varies at that point. Yeah. So we get a very good idea, probably by that 4th treatment. 3rd treatment, we know what changes we're making. 4th is how that neck is holding. And some people do, you correct it and it corrects and it holds, and others it wants it. Yeah, it's just so individual, that one. Yeah, but it gives you a bit of an idea. Yeah.
Sorry, I'll say it's on this introduction, but
Yeah,
as
right.
part of the treatment, physiotherapy.
Yes, so sorry, yes, I didn't, yeah, so we are physiotherapy based, yeah. We all are, actually. We did have one chiropractor who worked for us in Auckland, so yeah, at the moment we're all physiotherapy based. The training we do, there's no clicking or cracking, so it is sustained manual therapy, so it's very gentle, suitable for all ages. So we treat, we have had babies, treat sort of under 4-year-olds up to 90-year-olds or over, so very safe for all ages. So we're not ever taking people into end of range. It's quite a neutral position, and also safe with the osteoporosis side of things as well. But yes, it's something that it's a very specialised technique, so it's not taught undergraduate level. Yeah, so it's extra training you do on top of.
Can you tell us by looking at people, like imaging?
Absolutely, yes. So a common thing, yes, a good question actually. Common thing you'll see if people have weak neck muscles, their chin wants to sit up here. Okay, so our deep neck flexors help keep our head level. So there's sort of the two common things we'll see. Some people are either their head's way out here, or they're way out here and they're up. So you definitely, this is a very common one. And just how people move. So it's not all on movement. So in undergraduate level, used to go, well, we clear the cervical spine if they've got full range of motion. That is not what we see. So some people can have full range of motion and their neck is still not happy at the top. But it's that. It's often the chin up, and some people, I see it in a few, more so one bit for you guys, is this very, very prominent muscle through the front. So sternocleidomastoid. If this is really overworking, you know that those deep supporting muscles aren't very happy either. Yeah. So those are some quite common things you'll see. But good question actually.
Yeah.
What about people with hypermobility and Edley's?
Yes, so do see a few of those. With that, I've definitely had some that will respond really well. We monitor the treatment a little bit, and obviously we wouldn't push hard. And if someone's got, it's a hard one without going into the nitty gritty of the actual dysfunction, if people are swung right over, we wouldn't treat that as firmly, and wouldn't try. And some people you actually want to overcorrect the dysfunction, and someone with hypermobility you wouldn't do that. So just a slightly different way you treat it. Still can respond really, really well. The strength would be a big focus for them though. Yeah, and strength. So they could potentially take a little bit longer, but again it's individual. But they need to build up their strength in order to be able to hold the neck position. So that can take a little bit longer with people with hypermobility. Yeah, but definitely still respond well. Yeah.